Hello. Can you guys hear me?
Hi there, yes.
Hi. Yay. Okay. Thank you everybody for coming. Let me just put the QR code up so you guys can sign in.
Hello, friend.
Hi. Hi, Keith.
Hello.
Let me Okay. So this is the QR code. If you've never done it before, just like get your phone, go on the phone. Wait, what? Go on the camera app and then just like hover over it and it'll take you to like a Google Doc type of thing. I'll just leave it up for like a minute or two and then we can go ahead and get started.
Anna, you didn't see my keys?
Okay, does anybody have any problems with signing in?
No, not at all for me.
Okay, cool. I'm gonna stop sharing it. If you need it again, just let me know and I can put it back up. But, okay, put this. So yeah, welcome everybody to Mental Health Pals. Just so you guys know, we are recording the entire session and it's also gonna be available to you guys on YouTube. I think they're posting it the end of the week or something like that on Friday. Not too sure, but let me get the link for that to the Pals YouTube channel.
And FYI, I know based on an email I got that the YouTube videos are not up yet and they probably won't be up till next week, they said. So they're not immediately accessible.
Okay, cool. Thank you for letting me know. Because this is like a new thing for PALS that they're doing. So yeah, but I'll get more info on that. I can't find the link right now, but I'll do it towards the end of the session. But I think I could start by introducing myself. Well, my name is Megan. I'm currently an OB right now. It's crazy. This is my second term tutoring mental health. I did it for the first time last term and it went really well. And a lot of my students who continuously came, they got like level 3s. They did like amazing on their final. So I was like, wow, I think I'm actually doing something helpful. So I was like, okay, I'll do it again. Hi, Kimmy, no problem. You can, there's like no really start or end time. You can pop in whenever you want. But yeah, I'll send you the sign code later on. You can do it towards the end. But yeah, this is my second time tutoring. It's a lot of fun. I had tan, so yeah, I felt like that's also why I wanted to tutor because I know it's a really difficult class for a lot of people. So I was exactly in your position, like so scared, like don't know what to expect. Cool. And also, can you guys let me know who you have and what day? Just because since I tutor in the middle of the week, oh, okay, so today. Just because since I'm tutoring in the middle of the week, I'm probably gonna get students who already, like I know some people already took the first quiz yesterday. They might have it later on today or tomorrow, whatever. So just let me know. Tan just switched. Okay, cool. Just so that way I can like talk to or I can like accommodate all students who haven't taken the quiz yet, about to take it, stuff like that. Cool. Well, thank you for letting me know. And yeah, like I said, this is being recorded, so just maintain professionalism. It will be posted on YouTube eventually. What else? Oh, study tips. So if you guys do not have the textbook, highly recommend the textbook. You already have the ATI book. And I know Tan talks about it a lot, but I found it to be extremely helpful, is the success book. Did he mention that this term? Yes. I think it's like, dang, I forgot the color. Yeah, it's like a purplish, greenish, it's a rainbow book basically. But I highly, highly recommend that book, just because I know you guys are coming from intro to med surge, and I'm telling you right now, like mental health is like a different kind of nursing. So it's gonna force you to think in a very different way that you're not used to. Because I feel like with med surge, it's very like, here's the disease process, here are interventions, here are some meds, do that. And it's kind of a straight line, like you need to know your patho and all this. But with mental health, it's very like you acquire all this knowledge, like let's say about a condition, let's say bipolar. You learn everything about bipolar, like what it is, signs and symptoms, medications. Oh, and yeah, this is very medication heavy, but as you go along, you're going to be like, oh yeah, I totally remember that, blah, blah, blah. Wait, where was I going with this? But yeah, it forces you to critically think like a lot. It's not just like, oh, what is this? Oh, it's this. No, it's like, okay, here's the situation. What are you going to do first, knowing everything that you know already? So yeah, but I find this class to be really fun, but it's definitely going to be a different kind of nursing thought process. What else do I have to say on that? Oh, and you guys also have the proctored exam week 8. So just keep that in the back of your mind. I know it's really challenging to have quizzes every week, and then all of a sudden in week 8 you're like, oh, I have to take this big proctored. So that's why I would recommend making sure you read the ATI chapters and like keeping up with them every week, because you don't want to like wait all the way to the weekend of week 7 to read everything. And I know, and the mental health ATI book is like not too bad. It's not too dense. It's really like, it's enough information for you to like to grasp it, to understand it well. So yeah, don't forget about your proctored. And we can also like talk about, yeah, definitely not as big as med-surg. Med-surg is like this big, and that's all, it's like beep. But yeah, don't forget about that. We can also talk about that if you want study tips on how I did on that, because I did get a level 3, thankfully. I don't know how, but it was definitely, yeah, it's I still tell people till this day, like that was one of the hardest exams I think I've ever taken in my whole life. Thank you. But yeah, I felt like being in Tan's class really prepared me too. So it was a combination of that, keeping up with all my quizzes and readings and ATI stuff, and I felt really, really prepared. But that's like, oof, all the way down the line. We're only in week 2. So yeah, that's basically a little intro to this class, what I'm doing. And I love when you guys come with questions, just because like there's so much we can talk about, and I can go on for hours and hours and hours about this stuff because I love talking about it. But it also helps me because I also don't want to talk about things that you guys might already understand. So just come with questions, and yeah, I think that's pretty much it. Does anybody have any questions?
So I know for 10, I heard that DSM-5 is big in the quiz today, and
Okay.
DCI, which I still kind of don't know what that means.
Okay. Let me go ahead and pull out my notes. So you have him today?
Yeah, I have him tonight at 6.
Okay. Let me. So are you asking like what exactly is the DSM-5 or
Right. I know it's basically how the how mental illnesses are categorized, or the criteria for them.
right.
But I guess like how many questions can he ask about that? I don't even.
Yeah. Well, as nurses, we don't really use the DSM-5. Like, let's say we have a patient coming in with bipolar. I don't know why I always use bipolar. It's just like, anyway. Let's say a patient comes in with bipolar. You're not going to see a nurse like crack open the DSM-5 and be like, oh yeah, yep, he has this, 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 and this. It's more like, I feel like more psychiatrists, doctors, people who like diagnose mental health conditions use that because it's kind of like a guideline. It's kind of like it gives you all of these signs and symptoms, things to look out for. And like, let's say this patient says like, oh, I think you are presenting symptoms of bipolar. They would go in and say like, okay, are you experiencing this? And then be like, yes or no. Boop. And then it kind of sees like, oh yeah, like you're kind of aligning a lot with all the signs and symptoms of this condition. Let's go ahead and like move forward with therapy and stuff like that. They're not going to ask you questions about like, what is the third criteria on the DSM-5 about bipolar? They're not going to ask you questions about that. So don't think like, oh my God, I need to know the whole DSM-5 for every condition ever. It's more like, what is it? What is it used for? And why is it helpful? Does that answer your question, Jennifer?
Yes.
Okay, cool. I don't want you to like memorize every single bullet in that because
oh no, I don't think I have the ability to.
Yeah. That's why I was like, wait, don't do that. Yeah. Okay, somebody put a question. Hi, Rosie. Quick question. I always get confused with the weeks on the syllabus. I know assignments for week 2 are due tonight, but does that mean that tonight's quizzes is going to be on the assigned ATA readings for week 2 on the syllabus as well? No, it's usually on the week before. Dang, I wish I had a copy of your guys' syllabus, but yeah, so basically everything that you learned last week, which was week 1, is what you're going to be tested on this week. Because you guys take the quiz like in the beginning of the class, right? So you're going to go in, take the quiz, and then lecture after. Okay, so only the assignments are the week ahead, but the quizzes are the week before. Yeah, pretty much. Because if it says like in the syllabus, let's say like week 3, and then it has like all these assignments, you would want to get all these assignments done by week 3. But then all the readings are saying like, hey, during week 3, you should be reading this in preparation for week 4. Yeah. Okay, cool. No problem. And you guys can ask me like any questions as well if it's ever like school related or anything, because I know it's really difficult, especially being online, like trying to like create study groups and making connections and stuff like that. So yeah. Oh my God. Yes, I also have mentees. Keith is one of my mentees. Shout out to you. But yeah, okay. I'm getting sidetracked. Do you guys have any questions about anything? It could be from last week's material. If you guys already took the quiz, it could be for next week's material. Any questions at all?
Actually, can you go over the first, second, and third gen for medications?
Okay. Wait, are you guys already learning about medications?
Oh, well, because I took the test yesterday, so I'm in it like, yeah.
Oh, okay.
Or like if you want to go over that like later to help like the other people out.
Oh, you're so nice. Let me, dang, I wasn't expecting you guys to already start medications. Let me get my thing. I know that every well, Tam did. I'm pretty sure all the professors do too. They give out medication worksheets, right? And they have it posted. Have you guys seen them before?
She's for my class. She said she's gonna post it like tomorrow, I think.
Okay. I'm gonna tell you right now, those med worksheets are like golden. Like if you understand, like at first it's hard to understand because you're like, wait, what am I even looking at? But it helps you like kind of group all of these medications together because it's literally impossible to know every medication. You know, new medications are coming out all the time. So with this class, it's a lot of like learning all of the different classes and identifying you know, common side effects, contraindications, what is it used for, stuff like that. So I would, can you please go over these and these for week 1? Yeah, I can go over that too. Okay, Keith, I'm gonna hold off on your question about medications and then I'll go into the theories, if that's okay.
Okie dokie.
Okay. Let me pull them up. Oh. Okay, so the first theory is Freud's psychoanalytic theory. So this is like the id, the ego, and the superego, and it's always that example of like the iceberg. So in the id, it's your pleasure principle, it's your reflex action, it's your primary process, and that's the one that's like all the way down in the water. So that's meaning like it's harder for you to retrieve that information. It's not really coming to you. Like if you would have to think about it, you'd have to like really, really remember like, oh my God, like when was that? What was I doing? Stuff like that. The ego is your problem solver and your reality tester. That's the one that's like kind of like in the middle, kind of like, because your id is like, oh, I want to do this now. I don't care what anybody else thinks. And then your ego is kind of like pulling your id, like, hey, like, I think you should think about it first, don't you think? Like, why are you like, let's think about all the consequences. And then your super ego, that's your moral component. So it serves our conscience, it's right or wrong, they know the consequences, and this is either learned from like your parents or your surroundings. So id is your source of drive, it's your genetic pleasure principle, it what motivates us, but it lacks problem solving, it acts on impulses and reflexes. And then for the ego, it's the needs and wishes of the id, but that cannot be met with that immediate action. So it basically tells your id, like, let's delay that reaction right now so it can follow reality principle. Anna, I'm just gonna mute your thing if that's okay, just so that there's no like background sounds. Okay, so that's like Freud's psychoanalytic theory. And he also goes in, no, it's okay, don't worry about it. He also goes into talks about defense mechanisms, right? So this is what prevents us from like panic attacks, and it's the way that we cope with stressors. So it's not like when something bad happens, we don't just like crumble and shrivel and just like give up. We like build that like resilience. We like learn from past experiences. We're like, oh, like something like this happened to me before. What did I do to make it better? What did I do to like help myself? So, you know, defense mechanisms. And there's an example, like if a person has unwanted thoughts, instead of harming others, for example, like you let that energy go when you go to the gym, you run a lot, you like find a punching bag, just so like, you know, defense mechanisms, like how to better cope with things. Because you're not just gonna, when something bad happens, you're not just gonna forget about everything. You wanna like see like, okay, well this happened, how can I become better from that? Let's see. Oh, So you guys learned about transference and countertransference, right? These two topics are crucial. Can you guys explain what transference means? Or countertransference? Or yeah, just transference.
Transfers is like when the patient sees the nurse, or like the patient's like reminded of the nurse of like someone that they like know, and then countertransference is like it's either negative or positive. So like the nurse could give like for example, like let's say I'm the nurse and you're my patient, but you remind me of
Mm-hmm.
like someone I don't like. So like I could
Mm-hmm.
treat you like I would have a bias to like treat you wrongly as opposed to like being fair.
Wow, perfect. Keith, on the money. So proud.
Thanks. Thanks, mentor.
Yeah, so that's basically what it is. I don't know. Do you guys have any questions on that? So basically countertransference is like feelings that patient has to the nurse. Like, oh my gosh, if your patient's like, oh my gosh, you remind me of my mom, that's transference. And then the other way around would be like the countertransference would be like this patient is like reminding the nurse of someone before. It could be like from like just like their mannerisms, their name even. So yeah. And
So transference is from the
mhm,
patient to the nurse, and
mhm.
countertransference is the nurse to the patient.
Perfect. Yes. And I have a question here. So both can be negative or positive? Yes. So yeah, the patient can either have positive or negative feelings towards this nurse because the nurse reminds the patient of somebody, and it can also be the nurse has positive or negative emotions toward this patient because of whatever reasons. And let's see. Yep, you're welcome. And countertransference, even though like it is nice, like, oh, like look at my patient, she reminds me of my mom, for example, that's not good, right? Because you have how many other patients on your floor that you need to tend to, and that also talks about like the bioethical principles of like justice, of having to split your time evenly towards all your patients. You're not going to stay in one patient's room more than the other just because you like them more or they're nicer, stuff like that. Yeah, for sure. I'll go into those like beneficence, justice, veracity, all of that. So yeah, so countertransference, it's not therapeutic because of that reason, and because you're doing an injustice to other patients. So if you do see like any of these transference or countertransference happening to yourself, you need to either remind the patient of those boundaries. You need to be like, hey, like, oh, that's really sweet, but I'm not your mother. I'm not that person that you think I am. I'm your nurse, and I'm here to make sure that you're okay. Okay? Okay, that's transference and countertransference. Let me get the bioethical stuff. Okay, so there are 5 principles of bioethics. Can you guys either put it in the chat box, say it out loud? What are some of those principles? Justice, beneficence, veracity, yep. Autonomy, yep. Fidelity, yes. Is that 5? 1, 2, 3, 4, 5. Okay, perfect. So we'll start with beneficence. So that is the duty to promote good. So I always think about it like beneficence, benefit for the good of other people. So the next one is autonomy, and that's respecting the rights of others to make their own decisions. So that's saying like because we all know that patient has the right to refuse medication, right? Unless it's like some like 5150 hold or a Reese's petition, something like that. But if they don't want to take this med or they don't want to go through with this procedure, they have that right to say, I don't want it, I don't want to do it. And us as nurses, we can't force them to take it, right? We can't like shove it down their throat, or we can't like threaten them and be like, well, if you don't do this, you're gonna be in so much pain, blah, blah, blah. They have that right to say, yes, I want to do it, or no, I don't want to. So a patient can refuse meds with a 5150 hold. This is like where I get really confused. Oh, I should have prefaced this in the beginning. I know that I'm tutoring, but I'm also not a content expert. I'm like remembering things that I've learned. I'm like looking through my notes to help you guys. But if I don't know the answer to something, like we can go find it together, because I don't want to give you the wrong information too. But yes. And we all know what DTS, DTO, and GD is, right? Those are some common terms you're going to learn too. So DTS is danger to self, yep, danger to others, and gravely disabled. But yeah, they could definitely refuse if they're on a 5150 hold. Yeah, unless it's like really like critical, you know, and like the doctors involved saying like, oh no, this patient like absolutely needs it for like for the benefit of them, then yeah. But case in point, they always can refuse. So that's why autonomy is one of the 5 principles of bioethics. Okay, the next one is justice, and this is distributing resources or care equally. I kind of mentioned that when we were talking about transference and countertransference, and that's like making sure that you're dedicating your time and resources equally among everybody, regardless of their condition, regardless of who they are, what they believe in, whether you know them or not, blah, 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 blah. Everybody deserves equal treatment. Hey, are we good so far on beneficence, autonomy, and justice? And excuse me, these topics definitely like pop up again in like med surg and like OB and like all this stuff, because it's really, really important. So the next one is fidelity, which is also non-maleficence, and it's maintaining loyalty and commitment, doing no wrong to a patient. So maintaining doing no wrong. And the last one is veracity, which is one's duty to always communicate truthfully. So it kind of gets confusing because a bunch of them like overlap. Sorry, that's my dog. But the example I always like to give is like saying like, if you go into a patient's room and you say something like, oh, I'll be back in 5 minutes, you better make sure that you are back in that patient's room in 5 minutes. Like you can't tell them something and not follow through with it, because that's also going to make them like, oof, like, where is she? Where did she go? I thought she'd be here and you're not. Then it's kind of like, so that would be an example of like veracity, which is one's always duty to always communicate truthfully. So that's always veracity, telling the truth. Fidelity, maintaining loyalty and commitment, doing no wrong to a patient. So an example of this. This is kind of like, I know it's not really mental health, but it's like, let's say patient is like, I don't know why digoxin is the medication I'm thinking of, but let's say like this patient is taking digoxin and you get an order saying like, hey, give more digoxin, but you kind of see like, okay, he kind of is seeing, he looks like it's doing the most, or you kind of see like, yeah, I don't think this patient can handle anymore. So even though it goes to the order, you're not just going to give it, right? You would like call the doctor and be like, hey, like, I know you ordered digoxin, but he looks pretty, like, I think you should come and see him instead. So that's like where your critical thinking comes into play, recognizing signs and symptoms, stuff like that. Okay, let's see. Question, just to clarify, beneficence is doing good towards the patient and fidelity is doing no wrong towards the patient. Yes, exactly. Perfect. Oh my God, you guys are so smart. Why am I here? But yes, Rosie, perfect. So yeah, those are the 5 principles of bioethics. ethics, do you guys have any questions on that? I feel like this would be a good quiz question too. Like they would give you an example and then be like, okay, so which bioethical principle would this be? Okay, let me see. Yes, what's up, Anna?
Okay, so I know beneficence is basically doing good, right?
Yes.
And then isn't non-maleficence more like not doing any harm to your patient?
Yes.
And is it the same thing as fidelity, kind of?
Yeah. It's like, see, like that's where it kind of like overlaps, but for sure, like if they were to give you a question on the quiz, it's not going to be like that blurred line where it's kind of like, it kind of could be this, but it also could be that. It'll be like pretty obvious, I feel.
Okay, thank you.
Yep, you're welcome. I think like in the ATI book, it also does explain it in like a really, really good way. Yeah. Oh, it's chapter 2, page 9, just in case you guys needed it. What else? And you'll notice that in these tutoring sessions, we do kind of like jump around just like because everybody's in different classes and like things come up when like we talk about other things. So hope you don't mind that it gets a little crazy. See, talked about that. Can you go through Erickson? Yeah, sure. Let me get, sorry, I have so many just notes like everywhere and I'm just like, where is everything? Okay, so Erickson's theory, we know that there are 8 stages, and we use his theory a lot to formulate nursing interventions. And this is because like even if you guys notice like on your care plans and concept maps, there's always a place for Erickson because it helps you kind of put yourself in the patient's shoes and be like, okay, like what are they experiencing right now in their life that can like kind of help or prevent like this care that I'm giving towards them. You know what I mean? So the first stage, which occurs from, okay, yeah. The Erickson stages are really important. And I would say if you can identify, or if you have like a certain age range in your mind, then it'll be easier for you to like think of like, oh, a preschool children, that's like initiative versus guilt. Okay, we'll just go through it. So the first stage is trust versus mistrust, and this is between the ages of 0 to about like 1.5. And this is basically when a baby, so this baby is trying to develop trust. Oh, let me backtrack. So with Erickson's stages, in every stage, there's like 2 things. So for example, trust versus mistrust. There's always going to be something good, which is trust, and something bad, mistrust. Because of course, we would want these babies to grow up trusting people, right? Because if they don't fulfill or pass this, do you have to memorize the age? You don't have to memorize it, but like just have like a general understanding, because you're not going to think like, oh, an old lady is not going to be in trust versus mistrust. So just like have that clear. But yeah, so it's either going to be one good thing and one bad thing, and obviously we would want patients to achieve that good thing, because later on in life they're going to like suffer those consequences. So like for example, let's say this baby is mistrust and is now 30 years old. They could have problems, you know, with trust issues, trusting other people, trusting themselves. So, and that's not a good thing. So the first one would be trust versus mistrust. Example of that would be like, let's say baby is crying and baby knows that every time like I cry, I know that my mom's gonna come and like hug me and hold me. So it's developing that trust, like, oh, like the world isn't as scary as I thought it would be. Like if I ever need something, my mom is here and I can just call her. So that would be trust versus mistrust. The second stage is autonomy versus shame and doubt. And this occurs between the ages of like 1.5, 1.5, 1.5 to 3 years old. So this is like toddlers. So an example of this, excuse me, let's say like mom and baby are like playing a game. And like they're like playing a game together, blah, blah, blah. They're playing with blocks. And then all of a sudden the baby gets up and walks over to like the train set and wants to go play with that. And obviously we want to teach children like, yeah, like, you know, like you're your own person. You can go play with whatever you want to play. And if he wants to like go play with trains. So that would be like autonomy. Like, oh, he's saying like, I want to go do this because I'm done with the blocks. That's fine. Amazing. Perfect. But then the shame and doubt, so like the negative side of that would be like, let's say baby gets up and goes to play with the trains, and the mom is like shaming him, like, oh my gosh, like, no, like, come back here, like, come, I thought we were playing this game, not that game. So he like, now the baby like kind of feels guilty, like, oh, what, like, I just wanted to play with trains, I didn't know I was gonna get in trouble for this. And that can have like lasting consequences later on too, where like this person could be like, oh, like, I guess I always have to like follow the rules, I can't really do my own thing. Is this making sense? Are you guys like are my examples helping? Yes. Okay, cool. So that's, do we also need to know the development task in Erickson? Tasks, do you mean the stages?
In the text, let's say for infancy, the
Mm-hmm.
developmental task, it states forming attachment to mother, which lays foundation for later. Oh, I guess you did say that. So like, I guess, do we just need to know the developmental things that leads into like their crisis, like, you know, whatever it is, like trust versus mistrust, or like if there's the later years, for example, for like a older person, like integrity versus despair, like do we need to know, like it states in the book, looking back over one's life and accepting its meaning? So
okay, I get what you're saying. I think the stages are more important because it's also very like, oh, trust versus mistrust, and you're gonna think like, oh, baby like wants to trust the world and not have to trust his mom. So I don't think you have to like know the developmental task. You want to just identify, like, let's say they give you a scenario, you want to identify like, if this, like, first you have to identify like what age this baby is. So if it says like preschool or like high school, old age, baby, stuff like that. And then like you can tell from like the scenario, is it like a positive, is it negative? And that's how you know, like it'd be like, oh, he'd be in this stage as opposed to this one. So I don't think you have to focus on developmental tasks.
So like a possible question could be like, a client who is around 20 years old, what would their crisis be? Like, so their crisis may be like identity versus role confusion.
Yeah, or it could be something like, trying to think of an example, or yeah, just the example I gave, like, oh, baby is playing blocks with mom, but all of a sudden like wants to get up and paint instead. What would this be like an example of? So that could be like autonomy. Does that make sense? But like the example or the little scenario they would give, I feel like would be very like, they'd give you like a whole thing, like, oh, this baby has been playing for this, blah blah blah.
Yeah.
Yeah.
Thanks.
Yep. So that was autonomy versus shame and doubt. The next one is the third stage, which is initiative versus guilt, and that is 3 to 6. Oh my gosh, I totally like got these confused. I'm so sorry. But autonomy versus shame and doubt, I feel like that example is more like the, like teaching baby how to like potty train. because it's like now like you're like kind of pushing them like, oh, if you need to go to the bathroom, like you tell me and then we go. Because initiative versus guilt, like that's when it's like, oh, like I want to go play something else, and like the teacher could be like, oh no, come back here, and then like the kid feels guilty. So that would be initiative versus guilt. And initiative versus guilt, this is more like preschool age. So initiative versus guilt is preschool age, autonomy versus shame and doubt, that's toddler. Industry versus inferiority, that's like elementary, middle school. So industry versus inferiority, that would be ages 6 to 12. The next one would be identity versus role confusion, and that's ages 12 to 20. So these are like your teenagers who are very like, ooh, like, what is my style? Or like, what kind of person do I want to be? What do I want to wear? Who do I want to hang out with? So it's developing like that personality. And that's identity versus role confusion. The next one would be intimacy versus isolation, and the ages for that would be 20 to 35 years old, which I feel like that's kind of like our age group. So it's very like finding, like wanting a relationship, wanting to be with someone just so you aren't alone. The next one would be generativity versus self-absorption, and that's 35 to 65. I was going to say percent, 35 to 65 years old. So that one would be like, so at 35, you're probably like working at your job. So it's establishing that it's like your job, and then getting married, if that's on your plan, having children, raising a family. So that would be generativity, because you're like generating like good things for your life is how I remember it. Because the opposite of that is self-absorption. So instead of like dedicating your time to like your work and your family and your husband and your kids, you're just focused on you, which I mean, like, no problem with that at all. But like, of course, we want, like, as humans, we want that human interaction, helping others and stuff. I've always seen it written like generativity versus stagnation. Is there a difference between stagnation and self-absorption? No, it's basically the same thing. I think different texts like say different things, because I'm also used to seeing stagnation as well, but pretty much the same thing. And the last one is integrity versus despair. So this is ages 65 and older. So these are like older people, if they look back on their life, they think, oh my gosh, like, am I proud of everything that I did? Or do I have a lot of regret? Are there things that I would have changed? But integrity is the good stage, or is like what you want, because that kind of shows like you looking back in your life and being proud of everything and no regrets. So yeah, that's Erickson's. Definitely important. Yep, you're welcome. Let me see. Do you guys have any other questions?
I have a question about the, hold on, let me grab that.
Yeah, and then I'll answer your question too, Anna.
About the general, basic level of, or generalist, the difference.
Wait, what do you mean?
So like the responsibilities of the levels of psychiatric nursing practice, basically.
Psychiatric nursing practice?
So like between what does a nurse do as opposed to a psychiatrist?
Oh, okay. Thank you. I was like, wait, what?
Like that's how I feel. I'm like, what?
Yeah. Okay, so right at the top of my head, can nurses do therapy? What do you guys think?
No.
So we're not really there, like, it's like a very thin line. It's like, obviously we're there for our patients and we're there to care for them, like in that psychological like therapy, like, oh, like you can do this, let's get through this together. But it's more like, because with therapy too, like psychiatrists, they would like evaluate them. We don't really do evaluations like that. We do evaluations like more like, oh, like patient needs this med, we give it to them, are they improving? Or like, oh, we do this intervention for them, how are they doing? Let me find my notes on that. Doo, doo, doo. Where? Okay. So psychiatric mental health nurses says employ purposeful use of self, use nursing, psychosocial, neurobiological theories and research, work with people throughout the lifespan, employed in a variety of settings. So nursing is not only physical, but also mental, because it's part of the holistic care. So taking care of the whole person. So we work with people across the lifespan. Always in this. Yeah, it's mostly based on like therapy, diagnosing. We can't do that. We know that we have our NANDAs, and that, because with NANDA, it identifies diagnostic criteria and the nursing process and nursing interventions. So psychiatrists, they can say like, oh, this person has bipolar, but we can't do that. They can prescribe medicine, we can't. Yeah, because nurses, they do like talk to their patients and stuff, but it's not like full on therapy. And I think that's like the big difference on that. Is that okay? Did you want like to explain more?
No, I think that's okay. I mean, that's probably like the anxiety behind this first quiz is that everything seems straightforward, but I have no idea what to expect from Tan, so I'm like, I don't know.
It's also like, well, the first quiz always is kind of seeing like how you studied, and like you try to see how the professor like asked the question. So don't be too hard on yourself, especially on the first quiz. And it's also like the basics stuff. It's not like they're not throwing any medications at you. They're just like, hello, welcome to our class. This is what we're learning. So yeah, I get it, but you're gonna do fine. Don't worry. As long as you read, did your notes, listened in class, like you're good. Industry versus inferiority. Yeah, so that one, it kind of goes along the line of like autonomy versus shame and doubt, but it's like industry is like you're working like together, like it, like when kids play together, that would be industry. They're learning like how to help each other, how to take turns, talk, communicate like what they want from their friend or whatever. Yeah, basically like social skills. And then inferiority is also kind of like, oh, they want to like do things themselves, or they like don't work well with others, they think they're better than everybody else. Like that would be an example. Yep, you're welcome. And then can you please go over Sullivan, Hildegard, Maslow's? Yeah, okay, so for Maslow's, I'm sure you guys are familiar with Maslow's. They always tell you like, think of Maslow's hierarchy of needs. But in mental health, you're going to notice that safety is included in one of the basic needs. So let me backtrack. Maslow's is basically like this triangle, and at the top it's self-actualization. But towards the bottom, like if you're working from the bottom up, you have to meet those basic needs. So basic needs would include safety, for sure, especially with these mental health patients. You know, you don't want them harming themselves or hurting others, hurting you. So you always want to make sure that they're safe. Second, you always want to make sure that they have enough food, water. Those are basic necessities, making sure that they're well hydrated, eating. Because as we go on, like for, let me think of an example, like bipolar, for example, when they're in their manic episodes, they're going to be like running down the halls or like just like having flights of ideas and everything. And they're not going to have this time to like sit down and eat, you know? So you want to watch out for that. You want to make sure they've been sleeping as well. That's a big one. These patients who are in these manic episodes, they probably haven't slept for like days. So they're like, you know, if you don't get enough sleep, you kind of get like a little like, you become like, need sleep. My body's like, you know. So yeah, safety, food, sleep, those are your basic needs. So the idea with that is that you want to make sure that those basic needs are met so that you can go on and like help this patient progress, whether it be like educating them about their disease or going to therapy, doing things in the community to like help them feel better. So that's Maslow's. And whenever you're answering a question, if it's ever asking like priority, who to see first, what are you gonna do first, stuff like that, you always want to make sure like, okay, are their basic needs met? If yes, then go on with whatever intervention. If not, then that's where the priority is. Okay, that is Maslow's. Okay, Sullivan. Okay, so Sullivan, she talks about interpersonal versus intrapersonal, right? Do you guys know the difference between those two? Those are also really important terms. Interpersonal versus intrapersonal.
Interest between yourself, right?
Yes, perfect. Intrapersonal communication is with oneself. Only one person is involved. And like you guys said in the chat box, yep, it is self-talk. And interpersonal is always, yes, between you and someone else, always between two or more people. And the way that I memorize that is like, for interpersonal, it's like interaction, like you're interacting with other people. It's not just you involved. Let's see. Purpose of all is get through. Yeah, so for Sullivan's interpersonal theory, purpose of all behavior is to get needs met through interpersonal interactions and to reduce or avoid anxiety. Ooh, I know. Let me ask you guys this. As nurses, can we diagnose someone with anxiety? Whether it be like acute? Yes. Yep. Yay, good job. And why is that?
Because it's a symptom.
Yep, and it's a symptom, and also it's NANDA. So it's a NANDA diagnosis, so we can definitely say this patient has anxiety, whether it's from an acute event, something chronic, stuff like that. Can we go over the levels of an anxiety, please? Risk for anxiety. Wait, you guys are already talking about anxiety?
Well, that's chapter 4. I think it's mildly gone over in chapter 4 on ATI.
Oh, okay. So for that, because later on, I think it's in like week 6 or 7 or something like that, that's when we talk about anxiety, and then we talk about like the levels. So for this week, like this quiz, I don't think they're gonna ask you about the different levels of anxiety because that's later on. But do you want me to talk about it? If you want me to, I can.
You don't have to. I mean, I was just seeing the chapter 4 and it covers it, but if it's not really gonna be brought up, then I don't really need extra information.
Yeah, you'll learn about it later, I promise. But just like a small thing, the levels of anxiety, there's 4 of them. And of course, like with each level of anxiety is like a different intervention, because if you have mild anxiety, that's fine because that's like normal for everyday functioning. It kind of gives us that push to do a little better. And then as you go on, like if you're in panic mode, you can't really like communicate with someone like, oh, like if somebody's in a panic attack, it's not like you can ask them like, what did you do when you last had a panic attack that helped you, you know, because your priority right there would be to like calm them down, make sure they're okay, stuff like that. Okay, so that was okay. Talked about Sullivan. Now Hildegard. Okay, so the last one would be Hildegard Peplau. So she was influenced by Sullivan's work, and her thing is like the art of nursing and the science of nursing. And she also like talked about the levels of anxiety, which is what we just talked about, interventions to lower anxiety, aim to improve patients' ability to think and function. So yeah, she talks about the art of nursing, which is like, because it's like providing care, compassion, and advocacy. And the science of nursing is also like solving human problems, keeping them safe, preventing suffering, promoting growth, stuff like that. It's a lot of like looking at the whole person. What page in the reading is that mean that you're reading from? Oh, it's just PowerPoints and my notes that I took in class so far. Yeah, those are like all the theorists. Let me go really quick. Let's see what we talked about. Okay, we did talk about Freud. We talked about Erickson, Sullivan, Peplau, cognitive theory, Maslow's. Yep. Let me see. Okay, talked about this, stress, resilience. Yeah, we kind of touched on resilience, right? When we were talking about defense mechanisms, it's like your ability and capacity to secure resources needed to support well-being. So that's like the example I was saying earlier, where like if something bad happened to you, like you're not just gonna crumble and shrivel and like that's the end of the world. You're gonna like find ways to overcome that. So if you experience a similar experience in the future, then you'd know how to cope with it better. So resilience. And it also helps people face tragedies, loss, trauma, severe stress. And the important thing with resilience is that ability to recover. Okay. Okay, talked about DSM-5, we talked about NANDA, talked about that. Oh, you guys learned about therapeutic milieu, right? This is like a big one too. Yes. Okay. So therapeutic milieu is like the surroundings and the physical environment, and it's pretty much maintaining a safe environment for the patient, because as we know, here in mental health, our priority is safety. Of course, it's safety everywhere else, but like it's really critical in mental health to make sure that your patients are safe. Let's see. To maintain a therapeutic milieu, you always want to address the high-risk patients first. The safest place for mental health patients is outside right? That is like a really good intervention, especially if like they, like, let's say they haven't been sleeping for days, or like eating, like or they just have like a lot of energy and they need to get it out somehow. Telling them like, hey, like, do you want to like go outside for a walk, and like why don't you come and walk with me? Like that would be a good intervention. Outside. And later on, like, we'll talk about it even more with like how sometimes it might be better if they're in their room, sometimes worse. Are they good with a roommate, bad with a roommate, stuff like that. But yeah, maintain a therapy.
I think Middleburg said something about you wouldn't want clients in their room, or like you want to be careful with clients that are in their room too much or in their bathroom, because that's a place where they can do self-harm most often.
Yep. And also, like, we don't want to, yeah, I think you said this, but we don't want to leave them alone, right? Especially with highly depressed patients, suicidal patients, stuff like that. We always want to keep a close eye on these patients because, you know, we never know what they can do. We want to make sure that they're safe. Yeah, thank you for that input. Oh my gosh, I just found like my notes on like the psychiatrist and the nursing thing that you were talking about, Jennifer. Let me see. So psychiatrists, they require pharmacological interventions, they can prescribe, navigate treatment, and they can do labs. Nurses, on the other hand, they do 24/7 care, intervene, they evaluate patients' responses, they assess, they follow the nursing process. And then therapists, they provide therapy, whether in groups, whether individually, whatever. Yeah, I think we definitely covered that. Let's see. This is okay. Talked about that. Let's see. Oh, do you guys want to talk about like torts and stuff? Yes. Okay. So let's see. Okay, so tort is any civil wrong for which money damages may be collected by the injured party from the responsible party. So intentional tort. So torts can be intentional or unintentional. Intentional would just mean like, oh, I want to, or like, I'm going to inflict harm on this person. This is what I'm gonna do. And then unintentional is like, oh, I did something, but in the end, the individual got hurt. So an example of this would be, or I'm sorry, intentional torts would be assault, battery, false imprisonment, invasion of privacy, defamation of character, which is slander or libel. Okay, let's see. So an assault would be, let me see. Okay, so assault is like kind of like a threat, right? So assault is a threat. Battery is like when you actually lay your hands on that person, whether you slap them, punch them, whatever. Actually squaring up, yeah. You can have assault and battery. So that would be like threatening them and also laying your hands on them. And then there's false imprisonment, and you guys talked about restraints, right? You can't just put restraints on a patient just for your convenience. It's definitely like for the safety of them and for the safety of others. Because yeah, you can't just do restraints. That would be an example of false imprisonment. Invasion of privacy, yeah, that's like looking through other patients' charts that you're not taking care of at the time. That's like saying things to your coworkers about your patients. And defamation of character, which is slander or libel. I just want to make sure that, yeah, so slander is, that's or slander versus libel. Okay, so libel is when it's written and slander is when somebody says it. Oh, that's how I remembered it, because I was like slander, spoken, libel, written. Yeah, so those are torts. Can you explain the difference of malpractice and negligence? Yes, I think I have notes on that. Do you know what chapter that is? Oh, I found it. Okay, so negligence would be like you're kind of like malpractice and negligence. Okay, so malpractice would be like doing something that is kind of like standard. Well, this is how I'm explaining it. Okay, so malpractice is like you forget to do something that is like standard across the board. For example, it could be like forgetting to put the patient's bed on lowest position. That could be malpractice, because like everybody else knows to do that before leaving a patient's room. And then negligence could be like failure to like, let me see, like you're kind of just neglecting it, whether it be because it's more convenient for you and you just like give it or something. Let me see. Yeah, like knowingly neglecting. Yeah, kind of like taking the easy way out or like the easy route. And those are all examples of unintentional torts. Unintentional acts again, which are unintended acts against another that produce injury or harm. How is giving more than the dose needed by accident a malpractice? Oh yeah, that would be a malpractice because, so let's say you're giving, the order says 5 milligrams and you gave 10 milligrams. You know that as a nurse, we have like the 7 rights of medication administration, right? So we know to check the order 3 times. So clearly if you gave more than what was ordered, then you weren't following those protocols that are already in place for everybody else. Does that make sense? Like, yeah, like somehow down the line you didn't check that 3rd time, or you something, yeah. So basically, like if you're not following protocol, that would be an example of malpractice, because those rules are already in place and it, you know, like it's up to you if you want to follow with those, which of course we all will. Okay.
Would you say like malpractice is more like specific and like negligence is more kind of like a broad statement? Like say negligent, like you just forgot to, I don't know, lower the bed. I don't know. Or malpractice is something that you accidentally gave too much of something.
Yeah, I think that's a good way of looking at it too, because negligence is like, because well, in malpractice too, like you didn't intentionally try to give them more than the required dose. It kind of like just happened. But the way that they would want to prevent that is from like having those 7 rights of medication administration and blah, blah, blah. But yeah, totally right. Let's see. And we know that documenting is super, super important. If it's not documented, then it wasn't done. Let's see. Yeah, so with like restraints, we always know that is the last resort, and you can never ever see you'll never ever see an order that says restraints, PRN, agitated. You're never going to see PRN restraints. They should never be like on hand like that.
I did have a question about the restraints.
Yep.
It's like you have to. It's every 2 hours, correct? That you check on it.
Yeah, it should be like every hour.
In
Let
the
me see.
ATI book, it gives us like a age, like 18 years
Oh,
and then older is 4 hours, 9 to 17 is 2 hours, and then 8 and younger is 1. So I was kind of confused by that because
yeah, and that talks about the behavioral restraints, right?
yeah.
Okay, because what was difficult for me to understand too is these are like different restraints. Like these are not the kind of restraints that you would see like on a med surg floor that are like really soft and like foamy. Like it's not stuff like that. It's very like kind of, it's very like I think Tan explained it, like it was like a belt or something like that that's like also like on like the hands and stuff. So that's like really scary, especially like when we talk about like delirium, and for older people, like older people don't do well with restraints. That's just gonna like freak them out even more. But yeah, I have that in my notes too. That ATI book says 4 hours for adults, 2 hours for adolescents, but that's not like the restraints that they're just like there in bed, because you're not just gonna leave them there for like 2 hours or 4 hours without doing anything on them. You definitely like want to make sure that you're checking up on them. I would say even every hour, every like 15-30 minutes. Those rules apply for seclusion too, right? Yeah, just because patient is in a seclusion room, you're not just gonna like, okay, bye. Like you're just in there. No, of course you want to make sure, that they're not harming themselves while they're in there, while they're like doing okay, making sure like that they eat, stuff like that. Okay, seclusion, restraints. Let me see. Yeah, so restraints are always the last result. In general, we need to check patients every 15 in a psychiatric facility. Yeah, I would say every 15 minutes. Or I think every 15 minutes. I feel like that's more for if patient is on like suicide precautions. But you'll also see like for suicide precautions that they're most likely gonna have a sitter or have like a one-on-one kind of thing where somebody is there 24/7 watching them, even like when they go to the bathroom or whatever, like they cannot leave their site. You're welcome. Okay. Physical violence. Do you guys have any other questions? I feel like we discussed like all of it. Because I can go on because I can talk about your meds now, Keith. Well, if you guys have any other questions that like just spark up, just let me know. What's a 5150 hold? So this is a hold. Let me get my notes out. So it's a 72-hour hold. And the criteria for a patient. Okay, bye, Anna. Thank you. Good luck on your quiz. So the three criteria for a 5150 hold would be DTS, DTO, and GD, which we said were danger to self, danger to others, or gravely disabled. So if they have like one of these, then they could become on a 5150 hold. There's also the other common one is the 5250 hold, and that one is just a 14-day hold. And the same criteria applies: danger to self, danger to others, and gravely disabled. No, all three criteria doesn't have to be met. It could just be one. So yeah, 5150 is 72 hours, and 5250, how long is the hold for? So the 5150 hold, that's for 72 hours. And then the 5250 hold, that is a 14-day hold. So 2 weeks. LPS. Oh, let me see. I'd have to check on that. LB. Oh, okay. Sorry, I just needed like a refresher. So LPS, conservatorship, it says here, it's the legal term used in California, which gives one adult the responsibility for overseeing the comprehensive medical or mental treatment for an adult who has a serious mental illness. So I think it's like delegating, like, for example, like let's say a wife is like the LPS of their husband, because it could be hard for the husband, since like let's say he does have a mental condition, it could be hard for him to like make decisions, or like he probably like wouldn't listen, so like he's kind of, the wife would be like the person who call the shots basically. So like a power of attorney, yeah, definitely like a power of attorney, like Britney Spears. I don't know that example. What example is the Britney Spears? She has an LPS?
I think her father is her LPS or whatever, because he had like
Oh,
I guess a Maniac episode a while ago. Like, remember when she like shaved her head, had like that whole
yes.
down? So like, I guess
Iconic,
she had
yes.
a whole thing going on, and I guess it was a court order where her father is now the LPS, but
Hmm.
now people, it's like a whole underground thing. I don't know if it's underground, but like people are like
Yeah.
saying like she's like in confinement, like her dad's taking over her life, blah blah blah.
Oh, yeah, I have seen that on TikTok.
Yeah, exactly. So like the comments like wear a yellow shirt if you're in trouble, and she wore a yellow shirt or something like that.
Oh my gosh. Yeah, that's intense. But
Yeah,
yeah, that's what an LPS is. Just somebody who is like in charge of this person's plan of care, just because they're incapable or can't do it on their own. Yep. So yep. You may have mentioned this already, but do you think it's important to know different mental health settings? Like what do you mean, Salma? What do you mean different?
Like the acute care versus like community health programs versus whatever
Stuff
else.
like that. Okay. Yeah. No, you don't need to know like, yeah, you wouldn't need to know like, oh, patient is experiencing this. What kind of mental health setting would this person be sent to? No, I think they're just telling you like all the different kinds of options, because I feel like the general public, maybe when they think of like, oh, you're going into like a mental health facility, they're thinking, like a scary room, like really dark and like alone and like, stuff like that. But it could also just be simple things like out in the community if they need like somebody to talk to, or it could be like not even somewhere where they sleep. It could be like a weekly thing, stuff like that. It's just they have so many different kinds of mental health resources available for all these kinds of patients.
Okay, thank you.
Yep, you're welcome.
Megan, I
Yeah.
have a question.
Hi. Yep.
What tips do you have in terms of certain things that you should look out for? Like, for example, like you never want to pick the why questions, right? But in
Oh, okay.
mental health, I mean, I know things with like med surg, but in mental health, anything off the top of your head that you're like, okay, if you see this, don't pick that.
Okay. I think we talk more about like therapeutic communication later on, but some general tips I can give is you still never want to ask why. You never want to give like your own experience. Like, let's say you like, I don't know, for example, like your dad has like schizophrenia and you're taking care of a patient with schizophrenia. Like, you're not going to say like, oh, well, when my dad had his episode, he did this and it really, really helped him. Like, you don't want to like give your own personal things to somebody else, because yeah, it could be the same diagnosis or the same condition, but they could be experiencing it in a completely like different way. So you don't want to offer advice like that, or saying things like, oh, you should do this, you should not do that. Instead, you want to say like, oh, like, do you want to try like incorporating this into your everyday routine? Stuff like that. Let me see. Anything that I wouldn't pick in mental health. restraints unless absolutely necessary. And you always want to go from least invasive to most invasive. And you're also going to find like some questions are, I know they always tell you like assess first, assess. Yes, assess, but if a patient is in a crisis or something bad is happening, you need to intervene. And I think I'm going to keep reiterating that every week too. Like, if patient is like, I don't know, let's say like hurting themselves, is the first thing you're gonna do assess? No, you're gonna go in and actually do something about it. Safety, right? Yep, safety is always, always, always number one, especially with these patients. We always want to make sure they're safe, their basic needs are met. Yep, okay, so let's go on and progress with that. Let me see. Keith, what medications did you guys learn about yesterday? Or was it antipsychotics? I think he left. But I think it is antipsychotics. Is anybody else? Oh, okay. Is anybody? Okay, yeah, you're welcome. Good luck, Salma.
Oh yeah, it's antipsychotics.
Antipsychotics.
Yes.
Okay. Okay. So did anybody else already take the first quiz? Just curious. Hey, Trish. You did. Okay, cool. So I'll like go over it quickly just so you guys can also, and this will be good for other people too, because you're gonna learn this right after your quiz. Okay, so I'm pretty sure you guys know like this is what the medication worksheet looks like. Mine looks absolutely crazy. And I would recommend like putting a line through all the different kinds of classes. So the first one, for example, is your typical conventional first generation, low potency and high potency. And then the next one would be the atypical or second generation agent. So I would like put a line through that because like from here to here, like that is what this is all talking about. And then like the bottom here is like what it's all talking about, stuff like that. But here, I'll talk about like the difference between all of them. Okay, so on the first one, you're gonna see your typical first generation agents. So meaning when they first were learning about this condition, these were the first meds that came out. And since these were the first meds that came out, they tend to have more side effects as opposed to like a second generation agent. So under the first generation agent, you have like your low potency drugs versus your high potency drugs. Oh, and yay, you're welcome, Rosie. Good luck with your quiz. Also, because from week 2 and on, it's going to be a lot of medications. Always, 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 always know the generic name. The brand and trade name is nice to know. Okay, bye, Jennifer. Thank you. Good luck. The brand and trade name is nice to know because it helps you remember the med, but more often than not, he will use the generic name. So know the generic names. So you're gonna have your low potency and your high potency. So that just means like one is more potent than the other. And it's also important to know what form these medications come in, like whether it comes in PO, liquid, IV, IM, sub-Q. Like you want to know, or what is the one that dissolves under your mouth too, like a disc tab, something like that. You want to know like all the different forms of this medication that it's available, just so like let's say in a crisis, like you'll know like, oh, we can give this because there's like an IM version of that or something. Like for example, like trying to think. Like let's say that this patient is getting really, really aggressive. Maybe like PO wouldn't work as well because they're like, no, like don't put that in my mouth. You know, like they're going to be very combative. They're not going to let you like put a pill down their mouth. Then maybe like, oh, but they have like an IM version of it. Then maybe you could just do like an injection to help like the patient calm down. I know that was a very like kind of serious example, but just so you can get the idea of it. Okay, so thank you very much. Okay, yeah, you're welcome. Good luck on your quiz.
For the worksheet,
Uh-huh.
you know, it says typical agents and low potency, and then there's like a little, it says liquid and IM formulation. Does that mean it only comes in liquid and IM, or is just saying that's in addition to PO, it comes in
Yes.
liquid and IM? Okay, just making.
Yep.
Thank you.
In addition to PO, it also comes in that. Yep, you're welcome. Okay, so with low potency drugs, they're gonna have a high, they're gonna have anticholinergic side effects. So whenever you hear anticholinergic, I want you to think everything is drying up. Everything's drying up. So you're gonna have dry mouth, constipation, blurred vision, urinary retention, and confusion. But with these anticholinergic side effects, not only do you want to know what they are, and not only are you able to identify them, you want to know what nursing interventions you could do for each. So for example, dry mouth. Do you guys know any nursing interventions that you could recommend to your patient? Trish, I think your camera's on.
Sorry.
No, it's okay.
I was like, why is she waving? Sorry.
It's okay. Fluids. Yep. So for dry mouth, you would want to give, well, specifically, you would want to give sugarless gum. Hard candies can break a patient's teeth, especially if they have dentures. So they can also take frequent small sips of water to help with dry mouth. Okay. What about constipation? Nursing interventions for constipation.
Fiber?
Yep. You want to increase fiber. You can also increase their fluids. You can tell them to walk around the unit a couple of times, go and exercise, just to get, you know, the GI system moving. Next one would be blurred vision. This one's kind of tough. It could be like, you want to make sure that patient could wear like sunglasses outside, maintain clear pathway, because these patients are going to be high fall risk since they can't really see clear. You want to, maintain clear pathway, personal belongings within reach. Tell them not to just leave and get up out of bed whenever they want to. Definitely always use that call light. How about urinary retention? Do you guys know any nursing interventions for that? This is a big one. So urinary retention is when like their bladder is holding urine, but it can't come out, right? So they're holding so much fluid in them. So nursing intervention for urinary retention would be you want to advise your patient to urinate before taking the med, like at least try, and that'll help with the urinary retention. And then the next anticholinergic side effect, that one would be confusion. So nursing interventions for that, of course, you would want to keep them close to the nurse's station because they could just like leave and get up. They're a high fall risk. Personal belongings within reach again. Stuff like that. So definitely know your anticholinergic side effects. That's going to be super, super important, and it pops up a lot. Okay, so, this is the example I wanted to give as to why it's important to learn the different forms of medication is because let's say patient is cheeking a med. Do you guys know what it means when a patient is cheeking, specifically for like tablet medications?
They're holding it in their mouth, like on their cheek.
Mm-hmm.
Licking
They're
it.
not swallowing it, they're holding it. Mm-hmm. So they just keep it like here in their cheek, but you don't know, like they could be like saving so many of them to make sure, like I don't know, they could be saving it for like later on they want to like do something harmful, stuff like that. What I did when I was a kid, when my mom gave me vitamins, the Flintstones vitamins. But yeah, so that's why it would be important to know if this med comes in a liquid form, because obviously it's going to be 100 times harder for them to cheek a liquid med. And also, when giving medications to mental health patients, you as the nurse want to make sure that you saw your patient take that med, like you saw them swallowing it, like you because you can't just ask, like for example, like your CNA, like, oh, can you go make sure Mr. Jones like took his medicine and swallowed it. Like, no, your responsibility as a nurse is to make sure that they took it. Even if like you're having some reluctance about it, like you could be like, oh, did you swallow it? Like, let me see your mouth. Okay, good. Like you want to make sure that you gave this medication to make sure like they don't get any worse or stuff like that. Let me see. Okay. Oh, I think we'll talk about this a lot next week too, but since you guys have the quiz before next week's class, I'll definitely talk about it. Know the EPS, know it, which are extrapyramidal side effects. So this includes dystonia, akathisia, pseudoparkinsonism, and tardive dyskinesia. Know exactly like what that looks like. You can practice it, you can do it, but just know you have those 4 things like clear in your mind, because they're easy to like get confused on. And I remember also saying this like on the proctored, hint. But yeah, so know all of that. So we can go through that. So the first one would be Parkinsonism. So this is, in the name, it's just like Parkinson's disease. So common signs and symptoms you're going to see in these patients if they exhibit pseudoparkinsonism would be stooped posture, a shuffling gait, rigidity, bradykinesia, tremors at rest, so basically like this, like they're just sitting but their head is moving like this. And the last one is pill rolling motion of the hand. So that kind of just looks like this. Like these patients they literally like look like this. Looks like they're pill rolling. So that is Parkinsonism. The next one is acute dystonia. So this is your facial grimacing. So imagine for acute dystonia, it all happens like your throat and up. So that's your facial grimacing, involuntary upward eye movement, muscle spasms of the tongue, face, neck, and back, and the laryngeal spasms. And the laryngeal spasms, that's if like your larynx, like in the back, like they might like close up, so it might be harder for you to breathe. So that's what it is. So that's acute dystonia. Akathisia, this is probably like the easiest one to remember. It's basically like restlessness. So these patients, they can't stand still. They're always pacing the floor. Their feet are in constant motion. They're rocking back and forth. That's akathisia, just restlessness. And the last one is tardive dyskinesia. So this is like protrusion of the tongue where their tongue is out. This is their lip smacking. So they're always like stuff like that. They have this chewing motion, they have facial dyskinesia, and they have involuntary movements of the body and extremities. So those are super, super important to know. Like if I say, for example, if I say pill rolling, you should automatically know like, oh, pseudoparkinsonism. Or like protrusion and rolling of the tongue. You're thinking, oh, tardive dyskinesia. So make sure you get those side effects straight in your mind so it'll be easier for the quiz. Let's see. Okay, so for the atypical second generation agents, these medications are good to treat the positive and negative symptoms of schizophrenia. So this would be like clozapine's a big one, olanzapine, risperidone, ziprasidone. Those are all really big ones. For clozapine, this medication, the generic name is clozapine, brand name is Clozaril. These patients who take clozapine, they will have a high risk for neutropenia, which is the white blood cell count, and it also lowers the seizure threshold, so they're more at risk to getting a seizure. So nursing interventions for that, you want to implement seizure precautions, you want to monitor their white blood cell count, make sure you're not giving them too much clozapine, stuff like that. Let me see.
What's the range for white blood count again?
6 to 10, but let me double check for you. Normal range. Oh, it says 4,500 to 11,000. But you know, like if it's over 10,000, then we're thinking like infection. So yeah, so 4.5 to 10,000, I would say.
Thank you.
Yep, you're welcome. So yeah. So clozapine, Risperidone, neutropenia, lower seizure threshold. What else? For the medication asenapine, and the brand name is Safaris, that is the only sublingual second gen medication. Risperidone, clozapine, and olanzapine, they have a high risk of weight gain. Let me see. And then for third generation, as you can see, it's all aripiprazole or Abilify. So at least you only have one. And the last part, the treatment for EPS, so the antidyskinetic medications. So this is what you would give if your patient is now experiencing pseudoparkinsonism, acute dystonia, akathisia, and tardive dyskinesia to reverse those effects. So that would be like your trihexyphenidyl, diphenhydramine, benchtropin mesylate. That's a big one. Amantadine. Yeah. So like, for example, benchtropin mesylate, that treats EPS such as akathisia, which is restlessness. And then for tardive dyskinesia, those are like the specific medications. So that would be your deutetrabenazine and valbenazine. Trying to think what else is important for schizophrenia. Oh, make sure you know the positive and negative symptoms of schizophrenia. Like that is a big one. So when you're studying, I know it's kind of confusing because of the wording positive and negative, but I always think about it, if it's positive, that means you're adding something. You're adding something to this person that, or you're adding something to this person that's normally not there. And then negative would be like you're taking, in this schizophrenic person, like something is being removed that should be there. So that's your example of like, you know, like motivation, abolition, energy, anhedonia, stuff like that. So positive symptoms is what's not supposed to be there is now there. So they could have like delusions, whether they're auditory, visual. Yeah, these are your patients that are going to be like, oh, like I see something there on the wall, something like that. And the thing with that is like this is another one. If a patient is expressing like delusions to you, the first thing you want to do is you want to assess and ask them explicitly, like, are they telling you to do anything harmful to yourself or to others? You always want to ask about safety first. And also you never want to say like, oh, that's not real, like you're just making that up. You never want to like fight that delusion. You kind of like go along with it, but to a point, but you don't want to like buy into it, if that makes sense. So you could be like, so for example, they could be like, oh my gosh, like I see Spider-Man on the wall right now, and like you're looking and you know Spider-Man is not there, but you don't want to say, so the way that you would approach this patient is you could be like, oh, you see Spider-Man on the wall, like what is he telling you? Is he saying anything? And then the patient could be like, oh no, like he's not saying anything, he's just there, I just see him. Something like that. Yeah, never want to buy into the delusion. You never want to discredit the delusion, because for these patients, like I know for us it's kind of hard to understand, but they genuinely believe that Spider-Man is on that wall, and nothing you can say or do will convince them otherwise. Like they know for a fact, like they can see it, like there's no way of changing their mind. So examples of delusions could be grandiose, referential, or erotomaniac. Wait, what? Am I saying that right? Oh, erotomanic. So grandiose delusions, that's when they think they're Jesus, when they think they're an actor, like they just have like really, really high, they're speaking of themselves very, very highly. The next one would be referential delusions. So this could be like, let's say there are a group of students or patients sitting at the table over there. And let's say like I'm the patient with schizophrenia. So referential delusions would be like, oh my gosh, like those students who are or those patients right there who are sitting, I know they're talking about me. So they always think like all eyes are on them, basically. So they think like everybody's talking about them, everybody's looking at them, and that causes them anxiety too, because they're like, oh my gosh, like I feel like everybody is watching my every move. And then there's erotomanic, so that could be the delusion that, oh, all people are in love with me, stuff like that. With the positive symptoms, you're also going to see changes in their speech. So examples of this would be clang associations, a word salad, neologisms, echolalia, and flight ideas. So examples of this would be, so clang associations. So that would be like making words that don't make sense. Like, oh, you can ask the patient like, oh, what are you drinking today? Like, oh, I'm drinking my shalala. And then you're like, you're what? My shalala. So these are like made up words that don't make sense to other people, but maybe to the patient it makes, they have like meaning tied to that made up word. The next one would be like a word salad. So this one is like saying, like, oh, the cat, no, wait. Okay, so it'd be like, oh, the cat in the hat. Oh, I have a cat, his name is Billy. Oh, I also have a cousin whose name is Billy. Oh, my cousin with my aunt, she has like 5 kids. So it's kind of like you're making connections, the patient is making connections with what they're saying, but in like a very like crazy way. Like, see how I talked about like a cat, and then I talked about a hat, and I talked about like, yeah. So that would be an example of word salad. Next one would be neologisms. So that one would be making up new words. Oh my gosh, wait, did I say not real world? Don't make sense. Oh yeah, so clang associations, that would be like, it's not really any, it's not a real word in real life. Wait, let me see neologisms. Neologisms. Okay, yeah, neologisms would be like a new word. Echolalia would just mean repeating words. So whether that's with the nurse or another patient, like literally whatever you say, they will say it. They will say it. Like stuff like that. Like, oh, hi, how are you today? And they'll be like, hi, how are you today? So that would be echolalia. And then flight ideas, that would just be like they're just saying like anything that comes to their head. So then, let me see, other positive symptoms. So this includes like your depersonalization and your derealization. So depersonalization, just think about like you, like personal, like anything, like a change in something you see in yourself. So for example, you can like look at your arm and then be like, this doesn't look like, this is not my arm. Like I feel like my arm is too big, it like looks weird, like this is not my arm. So that would be an example of derealization. I mean, sorry, depersonalization. Deperson, your own body. Derealization, that would be relating to the environment. So you're seeing differences in like objects, like you're looking at like a couch and you're like, wow, that couch looks so tiny. And it's kind of like that dreamlike state, like things in your environment just are not how it should be. Yep, and then I talked about how if they are hearing voices, you want to assess first. You always want to ask, oh, you look kind of angry. Are the voices telling you something? What are they saying to you? Stuff like that. Other positive symptoms, the example of echopraxia. So I know we just talked about echolalia, which is repeating words, but echopraxia is mimicking behavior. So like if they like put your hand up, they put their hand up, just like copying their movements. And they also talk about waxy flexibility. Waxy flexibility. So it's basically like when you get their arm and you move their arm, like let's say you put it like this and they just leave their arm like this. And you're like, oh no, like you can put like your hand down, that's okay. But it's like they're a statue kind of. So those are all the positive symptoms. And then you have like negative symptoms. And negative symptoms, just remember like the 5 A's. Anhedonia, avolition, anergia, alogia, and affect. So we'll go through each one because it's super important. So anhedonia is the lack of pleasure. What used to be pleasurable to you is no longer pleasurable anymore. The next one is avolition. So avolition is the lack of motivation. And that's how I remembered it too. I was like, oh, avolition is the only one that sounds like motivation. So lack of motivation. Anergia is the lack of energy. Anergia. Alogia is the absence in speech. And then you have affect. So their affect can either be flat, blunted, inappropriate, bizarre. So, and they have like a lack of apathy. So they just don't care. They say, I don't care. So, and blunted affect. So that would be like, if you tell them a sad story and they laugh, that's what it is. So negative symptoms, the 5 A's, super, super important. Let me see. So there's schizophreniform and schizoaffective. So schizophreniform is before 6 months, before the 6 months, because for schizophrenia, you need to have like these signs and symptoms going on for 6 months. So anything before that would be schizophreniform, and then you have schizoaffective. Schizoaffective is either bipolar and schizophrenia or depression and schizophrenia. So it's like a combination of schizophrenia and like another mental health condition. Okay, let's see. In the acute phase of schizophrenia, like if they are experiencing like a manic episode or something like that, but it's acute, you might want to monitor their fluid intake, because they're going to have polydipsia, which is increased thirst. Like they will drink a lot. They will drink a lot. So you want to monitor that. Let's see. Oh, did he talk about the different pathways? Like the dopamine pathway,
Yeah.
serotonin?
I'm a little actually on
Yeah?
that.
Okay. So this is like mesolimbic, stuff like that. Okay. Let me see. Okay. So you have your dopamine pathway and your serotonin pathway. The dopamine affects the mesolimbic and the mesocortical system. So basically, in these schizophrenic patients, they have an excess amount of dopamine in the mesolimbic pathway. Like that's just what it is. So, so this is where you're gonna see like your positive and negative symptoms. So if there is not enough serotonin in the mesocortical pathway, then this is what causes your negative symptoms in schizophrenia. If there is imbalance in that mesocortical pathway, then yeah, negative and positive symptoms. So yeah, I'm sorry, I'm just like repeating myself. That's how like I take notes. The mesocortical is the serotonin pathway. So that's why it would give you your negative symptoms. So if you don't have enough of that serotonin, you're going to have like avolition, blunted affect, because you're not, like you just feel just not motivated or like yourself. The tuberoinfundibular pathway, this affects prolactin, and too much prolactin causes allomenorrhea. I feel like I spelled that wrong. Let me see. Or I think I meant oligo. Maybe I meant amenorrhea, which is the absence of period. Yeah, and then you also have the nigrostriatal pathway. Oh my god, it's a mouthful. Okay, so in a nutshell, the mesolimbic pathway is responsible for the positive symptoms. The mesocortical pathway is responsible for the negative symptoms. The tuberoinfundibular pathway, that's your hypothalamus and pituitary gland, which is the side effects of prolactin, which will cause the side effects of prolactin. And the dang it, I just gave it away. The nigrostriatal pathway, affects movement. Okay, so mesolimbic, positive, mesocortical, negative, tuberoinfundibular, side effects of prolactin, nigrostriatal pathway is movement.
Thank you so much.
Yeah, you're welcome. I hope I was able to clear it, because yeah, that I was like, wait, what? What are all these pathways?
That's exactly how I felt. I was a little overwhelmed. I have to review this.
Let me see. And when we're talking about meds, like for the first generation typical agents, if it's low potency versus high potency, low potency means there is low risk of getting the EPS, the extrapyramidal side effects, which are dystonia, akathisia, pseudoparkinsonism, and tardive dyskinesia. So if patient is taking a high potency first gen antipsychotic med, such as Pimozide, haloperidol, fluphenazine, yeah, those are pretty much the big ones. Then you would know to watch out for these extrapyramidal side effects and the signs and symptoms of dystonia, akathisia, pseudoparkinsonism, tardive dyskinesia, just so that, because you don't want to get them to that point. It's really, really bad. Let me see. For risperidone, where is risperidone? Oh, risperidone, which is a second generation med that causes hyperprolactinemia, and it also has a higher risk of EPS. Yep, that's for risperidone, higher risk of EPS. Let me see. For the medication Geodon, generic name is ziprasidone. It must be taken with 300 to 500 calories of food. You also want to monitor patient's EKG. Latuda, which is lurasidone, HCl, that should also be taken with food. Let me see. And for neuroleptic malignant syndrome, NMS, that's really important to know too. For that, I always remember the 3 Ds. So that is discontinue the medication. You want to administer Dantrium, DANTRIUM, which is a muscle relaxant. And third, a dopamine agonist like bromocriptine. So 3 Ds for the treatment of neuroleptic malignant syndrome is discontinue the medication, Dantrium, which is a muscle relaxant, and dopamine, administered dopamine, bromocriptine. So we have about 1 minute left, and we're towards the end of our session. Do you guys have any questions? I'll put my email in the chat box. If you ever need any help with anything, I'm here for you. Let's see. Yeah, it's a lot, and it gets crazy. Well, I feel like in the first weeks is where it's the most, and then you'll start to get used to it, and it won't be like such a large load. Okay, well, I'm gonna end this session now. I'll definitely update you guys about the whole YouTube posting thing on that. But yeah, that's my email if you ever need any help. And yeah, thank you for attending. I'll see you guys next week. And thank you. Yay, you're welcome. Good luck, everybody.
Bye, friend.
Bye.
Hi, Megan.
Bye. Thank you, guys. Thank you. You're so sweet. Good luck.